Good morning and welcome to this breakfast symposium on bone status assessment by REMS technology, an update on fracture risk prediction. My name is Giuseppe Guglielmi. I am full professor of radiology at the University of Foggia, Italy. And it is my pleasure today share with you the topic selected with very expert in the field coming from different countries. So I will start with short introduction and then I will introduce each speaker by the desk. As you know, osteoporosis is a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of bone tissue. The consequence of this is increasing in fragility, fracture, and the susceptibility of fracture of bone. In this slide, I'll also included the most frequent site of fracture that are the spine, and in this case the femoral head, showing two different images of the normal bone and the osteopenic bone with a deterioration of fracture, a deterioration of trabecula. What is the problem of the most important metabolic disease? This is osteoporosis. First of all, because this disease is underdiagnosed, because 90% of osteoporotic people never underwent the test to diagnose the disease. And secondly, there is a late diagnosis, because only 3% of women with an osteoporotic fracture had previous test. So, due to this concept is fundamental to prevent the risk of fracture and assess bone status in terms of quantity and in terms of quality. And in fact, the problem of the early diagnosis is the capability to assess the quantity and the quality of bone. And with this technique, we have the solution, because for the first time, we can combine together this possibility to assess the quantity and the quality of bone. And to this regard, I have to tell you that this is the unique and worldwide patented technology recognized to be able to answer to this question. So, as I mentioned before, we have the possibility to have a very qualified speaker, and in order to explain all the information, all the data related to this new technology, I have the pleasure to have with me Carmelo Messina, Giovanni Adami, Adolf Diaz-Perez, and Peter Ladzinski. So I will move now to the desk and I will introduce every single speaker. I invited Professor Carmelo Messina from the University of Milan to give his talk on fracture risk assessment by REMS in primary and secondary osteoporosis. Please, Carmelo.
Thank you very much for the introduction and for the invitation today. I have the pleasure to speak about this technique. I am a radiologist and I use it in my hospital. And these are my disclosures. In the next 10 minutes, I will briefly explain what is the REMS technology, and I will give some notes for what is the following presentation, and I will mainly focus on the usefulness of this technique in assessing BMD in primary and secondary osteoporosis. These are some of the disorders that we will consider, but the first thing is that the REMS technology is a different way to use the ultrasound for assessing bone mineral density of what we were using to do with the conventional ultrasound devices, so we can finally explore bone mineral density at central sites, which are the most important regarding the prediction of the more important fracture, the vertebral fracture and the femoral fracture. So this is the very important thing that is very similar to the bone mineral density assessed by DXA. And the way it works is basically related to the fact that it takes all the raw unfiltered spectrum of ultrasound wave that is reflected, and according to the fact that it's able to differentiate between trabecular and cortical bone, it creates a specific spectrum of this radio frequency waves of the patient. And this spectrum is then compared to reference spectrum according to the age, the ethnicity, for healthy and osteoporotic subject. So it creates ultrasound bone mineral density, the T-score values and zeta-score values, and also a fragility score, which will be better explained in the next presentation by Dr. Adami. Basically, it's an index of quality of bone. It is created during the acquisition of the spine and the femur directly, and it can be used to combine values from bone mineral density, ultrasound bone mineral density from REMS to quality to suggest some categories of fracture risk according to the patient. So when we can use this, we can, of course, we can use for primary osteoporosis, and we will see also that we can use this technique for assessing a condition that can cause secondary osteoporosis. The first thing I was wondering when I started to use is it reliable? Is it accurate technique? The answer is yes, because it's according to the study. This is a multicenter Italian study with about 2,000 postmenopausal women, in which they evaluate the diagnostic accuracy between REMS and the standard technique, which is DEXA. And actually, there was very good values of sensitivity and specificity, but also very good values of diagnostic concordance when we want to differentiate between osteoporotic and non-osteoporotic postmenopausal women. But also we found very high accuracy and diagnostic concordance between the T-score of REMS and the score of DEXA, but also between the bone mineral density value. So there was a very good correlation. So this is something good, because this means that it works, and we very interestingly, this will be talk in the next session, but just a brief comment that the technique is very precise, and this precision is also the data is very comparable also between different operators. So this means that the things that ultrasound is operator dependent doesn't really affect this device. I think it's really important, because we, as radiologists, we have this problem for ultrasound. So I think this is a very important thing. The accuracy was confirmed. The accuracy of REMS compared to DEXA was also confirmed in a very big European study, multi-center European study, in which the age of patients that were included spanned from 30 to 90 years old, so a very big range. Now moving to those conditions that relate to secondary osteoporosis, we start from type 2 diabetes. This was a study performed in Italy in which they compare 90 Caucasian women with type 2 diabetes mellitus with the control group. And what happened is that we are used to on the fact that bone mineral density by DEXA is slightly increased in patients with type 2 diabetes. And this was confirmed with a statistical significant difference between control group and type 2 diabetes mellitus patient with DEXA, but this difference was not statistically significant with the REMS. And another very important thing is that basically with REMS technology, we were able to diagnose more patients affected by osteoporosis, and in the patient with fracture, the difference was significant only for bone mineral density lumbar spine at REMS. Of course, there was a statistical difference of patient with BMD in fractured patient, but this was statistically significant only with REMS. The study assessed the patient with the REMS, with rheumatoid arthritis, only with the use of REMS, and it was found that there was a statistically significant difference between patient and controls. So this was a study in which only REMS was used, and it was effective in discriminating patient with rheumatoid arthritis and control group. This is very interesting because it's a study that was conducted during pregnancy. So pregnant women were matched with the control group, and basically the outcome was to compare the density, the bone mineral density value in a certain category, which is not very easy to assess with conventional technique like DEXA. And what was found was that there was a significantly lower value of BMD in pregnant women, with a mean relative reduction with the control group of about 8%. So this is something that made deserve more attention, and of course represent a very great possibility of evaluating the bone mineral density in pregnant women, which were not used to do with other techniques. Anorexia nervosa was another condition that was assessed, and again the ability of REMS was very comparable to that of DEXA. You can see that all the difference between the anorexia nervosa group and the control group were significant, both for DEXA BMD and REMS BMD, so absolutely comparable. And this is something that I think is also very important. The technique is able to diagnose, to just select a very small part of the bone and take information about this ultrasound BMD, so it can overcome some of the problem that we have with DEXA, especially at the lumbar spine, in which the presence of artifact is very, very frequent. And this is done, by the fact that the technique can automatically discard those spectra that are affected by artifacts, so it takes only the good spectrum and then compare this to the reference spectrum. I'm going to conclude. I hope to be in time, and I will talk to this very interesting paper by the group of Giovanni Adami, and then which was endorsed as the paper of the month by IOF. This is very interesting because it was done on a category of patient with peritoneal dialysis, in which the increased number of vascular calcification is present, and it showed that the REMS is not affected at the lumbar spine by this the aortic calcification, and the fact that it's not affected, it was confirmed, interestingly, by the use of lateral DEXA, in which there was a better correlation with the DEXA on a lateral projection, in which we know that aortic calcification are not in the field of view. So it confirms the fact that this technique is less affected by different kinds of artifacts, such aortic calcification or those related to spondyloarthrosis. So in conclusion, I want to say that this technique is accurate, is reproducible. It's a technique that can be definitely used regarding primary osteoporosis due to the very big studies confirming the accuracy and the diagnostic correlation with DEXA. But of course, the studies about secondary osteoporosis are increasing in number, so I really think that the utility of this technique can be really appreciated also in these categories. And the technique was approved in the national guideline in Italy for osteoporosis. So it is a technique that we will see in the next presentation can offer a lot to the diagnostic pathway of osteoporosis and fragility fractures. Thank you for your attention.
Thanks, Carmelo.
Okay.
We need to move to the next speaker, so I invite Dr. Giovanni Adami from the Rheumatology Unit, University of Verona, and his talk is titled REMS for the Evaluation of Bone Quantity and Quality. Please.
Thank you. Thank you again for the invitation to see this symposium of this very, very novel technique and very interesting technique as well. So I will talk about bone quantity and then bone quality, because we know that it's both important, and in particular condition, we want to know about quality as well as quantity. These are my disclosure. So we'll start with a little bit of introduction. Carmelo gave a very good introduction, so I will be very fast on that, as well as on the REMS basic principles, because Carmelo talked about that. But then I will focus on study and clinical study that confirm that REMS is a valid instrument for the measurement of bone quality and bone quantity. So, first of all, we need to measure bone mineral density. We know that bone mineral density is the single most important factor associated with fractures. And we need to measure at two specific points. That's the ISCD official points. We need to measure at the spine and hip. And this is tremendously important because this is the first ultrasound technology that allows to measure BMD at these sites. And again, we have an ultrasound which is radiation-free, and the REMS basic principle, as Carmelo showed us, we take this scan, this ultrasound raw signals, which are interpreted by the machine, by an algorithm that compare with normal bone with the pathological bone. And then we have a T-score, which is what we need, to give advice for our patient, treat our patient, and get a clinical decision on our patient. We have a Z-score as well, and we have a T-score stratified for each vertebra, as well as like we have in the DEXA scan. So we can choose the lowest one. We can interpret this novel technique, which is totally different from the past paradigm with the heel ultrasound, which has never been validated and will never take place in the diagnosis of the osteoporosis patients. We have as well the femoral neck, which is a very important site. And again, this is the report that you will have for assessing your patients. So we'll have, again, a T-score and Z-score with bone mineral density. But what is more important, when you have a novel technique, you want to prove that it's at least comparable to the gold standard, to the DEXA. But then you want to validate it longitudinally. Namely, you want to know that whether if you have a T-score which is very low, that will predict a fracture. That's exactly what has been done. And has been done on a very large sample size nowadays. In 2023, we have several studies doing that, and we have demonstrated that is a good sensitivity and good specificity, and more importantly, this was the first study that I have the honor to co-author, that demonstrated that REMS can predict at the same specificity and sensitivity, or even a little bit better than DEXA, the fractures in the follow-up. So what has been done here is that we have collected data from approximately 1,500 patients, very large age range from 30 to 90 years old, and then we divided these two groups and follow up these two groups for 5 years. And then we divided these two groups in those who had a fracture in the follow-up and those who have not a fracture in the follow-up. And then we ask ourselves, does the REMS can predict or at least classify the patient with the fracture as osteoporosis, an osteoporotic fracture? Yes, it does. And as well, the DEXA does that. So we have a classification that is correct, that is reliable, and it is consistent. Look at the regression between the DEXA and T-score. And REMS T-score and DEXA T-score, almost superimposable. And the specificity and sensibility of these techniques is tremendously high. But what's probably more important is that the area under the curve, so meaning the ability of discriminating patient that will fracture against those who will not fracture, was a little bit higher, probably slightly meaningful from a clinical perspective, but at least was superimposable to DEXA, which makes REMS a valid alternative to DEXA. especially for screening patients, because we have an instrument that can tell you this patient is going to fracture. And this is another way to look at this data is the odds ratio of discriminating a patient. Namely, if you fall into the category of osteoporosis with REMS, you are more likely to have a fracture in the follow-up, as compared to if you fall in the category of osteoporosis with DEXA. And this is extremely important. But then, we know that DEXA might have a pitfall. We know that patients on glucocorticoids fracture at lower BMD levels. They tend to fracture at minus 1.0, 1.5. And again, obese patients tend to fracture at a very high BMD level. So, in fact, we have the vast majority of fractures that happen in the osteopenic levels range. So we need something else. Yeah, we have clinical risk factors, but clinical risk factors are somehow and sometimes not so precise, and sometimes we have only just a few clinical factors. And we know the limitation of a fracture risk assessment tool as well. So what we want to measure now is bone quality. We have some types of hint from the DEXA, like the TBS and so on. But we have shown, when we have data from the literature, that they have fallacy as well. And that's what we have done with REMS as, for quality of the bone. The instrument is capable to provide a measurement of fragility, which is not density, which is not quantity. It's quality of the bone. This is the report of the machine that gives you a fragility score, which is range from 0, the worst, to 100, the better. And both at femoral neck and lumbar spine. So what is this new technology? Well, to develop this new technology, we have compared a number of patients with normal and, let's say, good quality, testified by the fact that they never had fracture in the past and in the follow-up, so they were healthy controls, against patients who are in the normal range, but they had fracture. And to do so, there's another study, very similar to the previous one, but in this case, we did not use the bone quantity to estimate the fracture risk in the follow-up. So again, more than 1,900 patients enrolled, very wide range, follow-up for 5 years, and then looking at the diagnostic performance of fragility score against DEXA and REMS T-score, so bone quality against bone quantity. And what happened was that the area under the curve for predicting a fracture in the follow-up was largely different from the bone quantity. So that means that might be really clinically relevant from this perspective. When you have a specificity that is highly statistically significant against another technique, you probably want to use that in your clinical practice, because you will find a lot of patients at very high risk. So that means that this is not only statistically significant, but probably meaningful from a clinical perspective. And again, was consistent across all ages, which is very relevant, because you wanna especially when you do screening, you wanna capture those patients very high risk in very low range of ages. So you want to tell the patient some additional information. You want to give patient additional information. They are on the osteopenic ranges. You don't know whether to treat or not. You need something else, and that might be the right instrument to do that. And this is again, another way to depict the result. This is the odds ratio, again, for capturing the patient with a fracture in the follow-up. And as you can see, the difference against DEXA was fairly large. In some cases, was approximately double the odds ratio. That means you have twice the chance of getting the right answer, of getting the right patient treated, of getting the right information for your patient. And what is more important and more clinically useful, let's say, is that we can couple the T-score classification and fragility score classification to give a more precise information to the patient. In this case, you will have, if you have a very low fragility score and osteoporosis, you will fall in a very, very, very high risk category, while if you have a normal fragility score and normal BND, you will fall in very, very low fragility. And that has been validated and should be replicated in other studies as well, but this is very, very important in this very large study, more than approximately 2,000 patient follow-up for 5 years, which is a very large cohort and long follow-up. We show that we can predict the fracture risk by coupling both bone quantity and bone quality. So in conclusion, we have very high quality evidence that for measuring both quantity and quality, REMS is a valid instrument. We have good performance, good discrimination ability to predict fracture, so we have not only the comparison with the gold standard, but we also have the validation on a follow-up cohort. And we have a novel technique, which is non-ionoring, but more important, can give you a very good information on lumbar spine, femoral neck, and also on bone quality. Thank you.
Thank you. Thank you. Now it's my pleasure to invite Professor Adolfo Diez-Perez from the Institute Hospital del Mar de Investigación Médicas in Barcelona. And the title of his presentation is Precision, Repeatability, and Diagnostic Accuracy of REMS Technology. And this is one of the most important criticisms that people move when we're talking about ultrasound. So now it's your job to demonstrate the opposite in this case.
Thank you very much, Mr. Chairman. Good morning. This is my topic for today. Actually, my task has been made very easy by the two previous speakers, and I will try to focus on these precise aspects. Let's start by the International Vocabulary of Metrology definition of precision and accuracy. Precision, also called the deviation of a measurement around the others, and accuracy, how close is to the truth the measurement we are calibrating. And perhaps it's more graphically described here. On the left, you see a measurements with low precision and low accuracy. In the middle, with high precision but low accuracy. And finally, on the right, a measurement method that has both precision and accuracy. This topic has been specifically addressed in this paper published last year in a multi-center Italian study. And the goal of the paper was to evaluate the change in the values of femoral neck BMD, total femur BMD, and fragility score between two REMS scans, two different devices, REMS 1 and REMS 2, analyzed by the Wilkinson text for assessing the systematic bias, and also the intraclass correlation coefficient to assess the reproducibility of the method. This is the intraclass correlation coefficient for the two devices. As you will see, the values are well above 0.9, almost perfect. 0.98, 0.97, and 0.998. So the values of femoral neck for these two REMS acquisitions were exactly detecting the degree of osteoporosis in the same way, the two devices. With respect to the DXA measurements, and has been already mentioned, there was a comparison versus the DXA technique, assessing the concordance between the two methods by measuring the kappa coefficient, the Cohen's kappa coefficient, that is showing the diagnostic agreement between two measurements. And they assess the differences of femoral neck BMD and total femur BMD for both DXA versus REMS. And these differences were assessed both by the Wilkinson rank test and the Blunt-Allman method. This is the Blunt-Allman, and it's a very useful method for comparing measurements. And you see here in this group of patients with primary osteoporosis and measurements at the femoral neck that almost, if not all, the measurements are lying in the line between the average, the mean, and the interval of plus minus 1.9 standard deviation. That means that there is a very good precision of all the measurements because all refer to the same degree of measurement. And the already mentioned Italian multicenter study was assessed the accuracy and precision of these REMS in comparison with the gold standard DXA in this multicenter study. And again, these values that you already shown a very excellent sensitivity and specificity, both for femoral neck and lumbar spine. The diagnostic agreement, remember that a kappa-Cohen coefficient above 90 is excellent, is almost perfect. In this case, with no tolerance, was very close to 90, and accepting a 0.3 T-score tolerance range was almost 100%. And importantly also, the repeatability, assessing the inter and interoperator coefficient of variation was also very, very good, 0.32 to 0.54% in different points and for the different measurements. The correlation is very clearly displayed in these two graphs on the left at the lumbar spine and on the right at the femoral neck, showing an excellent correlation between the T-scores as measured by DEXA and by T-score, with R values that are above 0.9 in both cases. And again, the Blunt-Allman test show a nice clustering of all the individual measurements around the mean plus minus 2 standard deviation in clinical conditions, so not in experimental conditions. Another set of data come from the European Multicenter Clinical Study, and pretty much the same range of values, excellent sensitivity and specificity both for femoral neck and lumbar spine. And also the discriminability between patients with and without fracture was also very good, showing this area under the curve of 0.68 and 0.64 for REMS T-score, both at the femoral neck on the left and at the lumbar spine on the right. This has been put together in a consensus paper organized by a working group of the ESCEO. And in this paper, they came up with about the same results. An intraoperator precision for lumbar spine of 0.38, and for femoral neck of 1.5%, excellent if you compare with DEXA, for example, and a least significant change of 0.32% for lumbar spine and 0.88% for femoral neck. What indicates that this technique is excellent for short-term follow-up because it's able to detect minimal variations that are already significant. The sensitivity and specificity for both lumbar spine and femoral neck about the same, with a very good correlation degree between the two measurements, the gold standard DEXA and the REMS, always above 0.9. And the agreement in measurements was also very good, with a Kappa-Cohen's coefficient in the almost perfect range, 0.94 and 0.93 for the spine and the femur. And finally, the new concept of fragility score for measuring bone quality. And these, the characteristics of the technique have been also assessed by studying the intraoperator repeatability and performing repeated scans on the spine of femur by experienced operator for one of the two main anatomical sites, the spine and the femur, in 6 males and 9 females. This and also the inter-operator repeatability, in this case assessing the measurements taken by 3 different operators, 1 experienced and 2 newly trained, and with the same set of measurements. And this is the result. The inter-operator repeatability show a coefficient variation of 0.49% for lumbar spine and 0.43 for femoral neck, and importantly, the inter-operator repeatability was of 0.73 and 0.64 respectively for the spine and the femur. So, fragility score is able to detect minimal skeletal changes that are not attributable to the intrinsic variability of the method. So, in conclusion, ladies and gentlemen, REMS technology shows an excellent precision, repeatability, and diagnostic accuracy. And with this picture of how we made the measurements in our center, I would like to thank you very much for your attention.
Thanks. Now it's my pleasure to invite Professor Piotr Lekzinski from the Department of Rheumatology and Internal Medicine, University of Poznań, Poland. Please.
Good morning, ladies and gentlemen. Good morning, Mr. Chairman. Thank you very much for inviting me here for this symposium and to share our experience from the Polish perspective using new device, REMS. Nowadays, we have 2 techniques to obtain bone mineral density. This is classical way, DEXA, and the alternative way, which is called REMS or REMS. I would not like to double information which you have heard from the previous distinguished speakers, so we know what REMS densitometry is. But from my clinical point of view, it's very important that it is a difference between REMS technology and previous known quantitative ultrasound technique. First of all, QS is based off a simple spectral phenomenon. And you have heard before, REMS is based on the complete and complex analysis of ultrasound spectrum as a whole. So this is the most important. And the second one, the QS techniques, we know a couple of years before, were dedicated to the peripheral sites. And REMS technique is dedicated to the axial sites, so femoral neck and lumbar spine. It works in the clinic. So we use it in the clinic because of very nice smart, friendly software, guided software, and we can obtain the images with printout in about 80 seconds from lumbar spines and about 40 seconds from the femoral neck. In this device, we have automatic identification of the bone surfaces, and we can find the region of our interest at the lumbar spine and the femoral neck. The most important from the clinical point of view is also that non-diagnostic scans are automatically excluded. So we can reduce the false results, false positive or false negative results automatically. And also, you have heard about artifacts from my distinguished previous speakers. Also, soft tissue calcification, osteophytes, syndesmophytes, fractures, compression fractures, areas are automatically excluded. This is very nice from the clinical point of view. All this information were done before, so I will not follow up then. We started a project which we called in Poland, in Poznań, usefulness of REMS densitometry in the diagnosis of osteoporosis in patients with rheumatic diseases, a specific population. You saw here some publications. We done 1,400 REMS scans to this time. It was interrupted because of the pandemic time, because my work, Department of Rheumatology and Systemic Connective Tissue Disease and Immunotherapy of Rheumatic Diseases, was involved in the care of patients with COVID-19 for 2 years. This is our real scan where we can find our region of interest, the head, the femoral neck, trochanter. In our opinion, technique is convenient for the patients and for the operator. This is the real scan from the lumbar spine where you can find L1 and L2. In our opinion, operators' training seems to be quite easy. And I think that after 50 scans, the operator can do the scan in a proper way with good results. I prepare 4 patients for you, real patients. The first patient is 84 years woman with long-standing aggressive rheumatoid arthritis. We expected in such a patient a very low bone density. We expected from the clinical point of view of osteoporosis, we expect fractures. And if you see here, we performed vertebral fracture assessment. So 7 fractures, mild, moderate, severe at the lumbar spine and also at the thoracic spine. From the clinical point of view, not technical, not scientific point of view, we would like to have osteoporosis in the sense of BMD. But if we saw such an image, it is sometimes very difficult using DEXA because vertebral fracture assessment, this is also a DEXA method. So we performed the right femur because we can't do it on the left side because of our arthroplasty, see, in this woman. If got expected low BMD at the femur, right femur, you can see here the T-score was -3.3. When we performed the same site using REMS method, we also got similar results. T-score is -3.2. When we done DEXA from the lumbar spine, it's scoliosis, fractures, so we obtained BMD, but only low BMD, without criterion of osteoporosis. So from the clinician point of view, it is difficult to explain how it is. When we performed REMS at the lumbar spine, you can see here the 4 vertebrae are in red, so we've got the very low bone mineral density with T-score minus 3.4. So REMS do not overestimate the bone mineral density. Patient number 2, 37-year-old man with the aggressive ankylosing spondylitis with numerous of syndesmophytes on the X-rays shown here. When we performed DEXA, you can see here Z-score is 3.5 and plus, and using REMS method, you can see green vertebra L1 and L4, which are normal, and we saw also here yellow 2 and 3 lumbar spines. So in total, we've got the results of Z-score minus 0.9. So this is also a case when we didn't get the overestimation of bone mineral density. Patient number 3, 39-year-old man with aggressive spondylitis, ankylosing spondylitis, also with numerous syndesmophytes, but this patient is a little bit elder. So I would like to show you that also is a correlation, negative correlation between T-score. Here you can see 5.7, L1, L4 using DEXA method, and using REMS, we've got the T-score results minus 0.1, minus 0.0, so L1 and L4 vertebra in yellow color, they are a little bit lower, and the L2 and L3 are in the normal range. So also this is a proof that the REMS method does not overestimate bone mineral density at spine. And the same patients, correlation between BMD obtained from the DEXA and the femoral neck, minus T-score minus 1.2 and minus 1.4 from the REMS machine. And the last patient, this is very old woman with bedridden woman with multi-comorbidities, with high scoliosis. This is also a technical problem to do the DEXA, and we use bedside mobility equipment of the REMS, and we've got expected results with very low bone mineral density and the lumbar spine, minus 3.5 and minus 3.6 in the femoral neck. The very interesting was the situation from the clinician point of view in that patient, that after first application of the ultrasound probe, we've got the image and the result. So the doctor finds good. We have the result and what we are expecting. Of course, we saw some limitations. The first of all is potential issues related to vertebral visualization in very obese patients, what you can see on the left-hand side. And the next limitation is also, this issue are related to the vertebral visualization in patients shortly after eating. You can see on the right-hand side a specific echo, so sometimes the image of the lumbars are very difficult to obtain. And maybe in the subpopulation of patients with systemic sclerosis, progressive systemic sclerosis, where the patients have a peristaltic impairment, it will be not very clear and find the good image. Nevertheless, you can see here the many of advantages of the REMS technology. So in conclusion, 2 slides only more, our section of the metabolic bone diseases and osteoporosis of the Polish Society for Rheumatology is preparing updates of our recommendations which were published in 2015 and 2017 only in Polish, but we are preparing now, and I think that it will be published in 2023 in Polish and in English, new recommendations, and we would like, and we are convinced to include RMS densitometry, and we are sure that RMS densitometry can be used in the diagnosis and monitoring of osteoporosis as an alternative method to the DEXA, especially in the population in patients, women and men between 30 and 90 years old. Whenever possible, in our opinion, it is recommended that International Society for Clinical Densitometry recommendations are also followed for when performing and interpreting RMS densitometry. And when we have the inconsistent results between DEXA and REMS, the lower results should be used as the basis for clinical decision, and the method by which it was obtained should be preferred to follow-up measurements. Thank you for your attention.
Thanks to the speaker, now my job is very easy because I simple to summarize the most important topics that they underlined during the presentation. So again, the problem of this the most important metabolic bone disease is related to under-diagnosis and late diagnosis. So it's crucial to prevent the risk of fracture. And based on this, how are the technology that are available to solve this problem? We know that DEXA is recognized by WHO as the gold standard method to assess bone status. But this technique, as already been told by the speaker, is able only to recognize 60% of the risk of fracture. So this means that there is another significant part that is not detected by DEXA technology. So in addition to bone quantity, it's important to solve the problem related to the other aspect, different for quantity, that are the quality. With this technology, with the REMS technology, we have finally the opportunity to combine quantity and quality, so we can solve the problem. And you know that the previous ultrasound technique were able only to analyze the peripheral site, like calcaneus, finger, phalanx. And you know how sometimes it's different to extrapolate the data coming from peripheral to the central spine and where the fracture occur. So this is a non-ionizing technology with all the advantage coming from not using of X-ray radiation, and takes into account the parameter of the T-score, so quantity, and fragility score, quality of bone. When we talk about ultrasound, the major criticism came from the fact that this is a technology too influenced by the operator. In the previous presentation has been shown that this is not the case, because the coefficient of variation is very good, and the accuracy and the diagnostic agreement are very important as a result. So in this case, we can say that this technology is influenced by the operator, because the data reported in the literature demonstrate that this is not applied in this particular case. Another problem related to the aging population, the presence in aging population of the calcification of the aorta, ossification of the ligament, degenerative osteoarthritis, especially evident at the level of the lumbar spine. And in fact, the WHO recommend not to use the DEXA at the level of the lumbar spine after the age of 65. And in the general condition, the osteoporosis occur especially after this age. So with DEXA, we can't analyze, we have not to analyze the spine after 60 age because of this influence. But in the case of REMS technology, the spectra of the scan are not included, and only the scans recognized in the spectra are analyzed. So this means that other conditions that falsely increase the value of DEXA are not considered. So this is another advantage. Considering this parameter, T-score coming from the REMS and the fragility score together give a better idea of the risk of fracture. And in fact, they can scoring a system in 7 areas where you considering this parameter, and then you can extrapolate normal condition, osteopenic and osteoporotic condition, based on the result obtained combining the two parameters. So the fragility score is showing a superior performance in fracture prediction and is a very valuable tool to detect a short-term fracture risk. Which are the most important advantage of this technology? So, operator independent, portable, radiation-free, and automatic progression and analysis of the data acquired. Exclusion of degenerative change of the spine, so exclusion of artifact. Very good precision and accuracy. Early diagnosis and prevention, assessment of the quality of bone, and possibility to analyze short-term monitoring of the patient. Has been already shown in the previous presentation how this technology can be used in different clinical conditions, starting from orthopedics, oncology, gynecology, rheumatology, internal medicine, dialytic patient. And several articles published already demonstrate how can be used in this particular condition. But in addition to this, our Minister of Health include now this technology in the guideline for diagnosis, risk stratification, and continuity of care for fragile fracture. And also, this technology has been recognized. It is under endorsement of the Italian Society of Osteoporosis, Italian Society of General Practitioners, and other societies that recognize the use of this technology and recommend the use of this technology in daily clinical practice. And also, we have not to forget the fact that the cost of the exam performed to assess osteoporosis. We have to deal about the increasing cost of the health system and using a technology that is cheaper compared to the X-ray based technology. I'm thinking about DXA, about QCT, about other technique. Then you have to think that the cost of the procedure is not to be forgotten, because it's another important, crucial point in the management of a disease that need a continuous follow-up. So the REMS technology has a very promising result at the moment, but we have not to conclude our study about the result we obtained today, because there is some future in this technology. And first of all, the possibility to investigate other anatomical sites where fragility and insufficiency fracture occur. I'm thinking about the sacroiliac joint. Everybody knows that fragility fracture, insufficiency fracture at the sacroiliac joint are very common, especially in osteomyelitic condition. So this is another study that can be performed, a new study. Other anatomical site to investigate can be the long bone like the tibia. There is another place where some fatigue fracture occur. But also, I think the very important area to explore with this technology is the possibility to evaluate the soft tissue component. In particular, I'm thinking about lean mass. You know that with increasing age, there is a degenerative change, and the lean mass move to the adipose degeneration of the lean mass. So this is a part of the sarcopenia. And I think that if this technique will be able to combine also the advantage coming from the evaluation of the bone and the soft tissue, because both play a significant role in the management of the osteoporosis, that can be another important goal to be reached in the next future. So with this, I really thank you for the attention given to this symposium. I also thank the speaker for the excellent presentation, and I also thank the attendant to be here at this early symposium. Thank you again.